Hello friends. This video shows how to manage Phaco when the CCC is compromised. So this is a case of intumescent cataract, and there was an Argentinian flag sign which happened at the first nick. So the rhexis was not proper. So what I have done so far is I have made two semicircular rhexis on either side of the Argentinian flag by using vanas, and now I am preparing for the Phaco. Now, the main principle of doing Phaco in such case is not to allow this anterior capsular rupture to go to posterior capsule, and the main movement which does it, or which allows the anterior capsular rupture to go behind, is the deepening of anterior chamber. So the anterior chamber pressure should be always kept low. So to achieve that, what I have done, I would like to show here on the left side of the video. You can see the irrigation pressure. I have kept it just 50 centimeters of water, which is roughly equivalent to 35 to 40 millimeters of mercury. So I am working at a very low IOP here. You can see my careful maneuvers for trench and divide. They are very small movements so as to avoid any distension of the anterior capsule and the posterior capsule. So the maneuvers have to be very careful. As you can see here, the AC is kept on shallower side. In fact, during Phaco, you can see some fluctuations in the anterior chamber indicating little bit of surge. But there is never deepening of the anterior chamber as I am working at just 50 centimeters of bottle height or the IOP. The Phaco has to be used very carefully. I have already filled the anterior chamber with Hylucoat, which is similar to Viscoat, which is protecting the endothelium. The foot switch control has to be good. You have to give Phaco only when the tip is occluded by the nucleus, and be very careful in the anterior chamber to avoid any jerky, extensive movements. And always remember, when you take out the Phaco probe, you have to use the same maneuver as we use in case of a PC rent, where we inject the viscoelastic from the opposite or the other side port. Before coming out, stop the irrigation, keep injecting. Now here you can see a capsular tag, a small capsular tag has come into the incision along with the probe, but this is not vitreous, it is just the torn capsule which is there. So I used my Sinski to pull it down because I don't want it to get again caught when I'm introducing the coaxial IA probe. So again, for the IA, I am keeping the IOP low at 50 centimeters. You can see that even at this low bottle height or low IOP, I can manage all the things without any problem. In certain machines, you may have to lower the vacuum and the flow rate, but it is possible to do it very safely if your maneuvers are very delicate, avoiding any distension of the antechamber as well as the back. While you are near the capsular tags, be just careful that you are not holding the capsular tags. So just allow a moment to realize whether you are holding the cortex or whether you are holding the capsular tag. In such cases, avoid excessive peripheral polishing because you may catch hold of the capsule anytime and can tear the posterior capsule. Again, while withdrawing the probe, remember you have to avoid fluctuation in the anterior chamber which may allow the anterior capsular rupture to rip behind. So in such cases, it is better to keep the AC on shallower side. A little bit of surge is welcome. Use Hylucoat or Viscoat to protect the endothelium throughout the procedure. If you want, you replenish it in between so your endothelial safety is not compromised. Now in this case, because I found that the bag is intact, and I can place a single piece IOL. You can always go for a three-piece IOL in case you have doubt. So you can place it in the sulcus. In this case, the posterior capsule is intact. So I'll be placing this IOL in the bag, but perpendicular to the axis of the Argentinian sign, so that it gets good support of the bag, the fornices of the bag, because these haptics of this single piece IOL must rest inside the bag and should not come out of the bag at any place. So I have placed the lens in the bag and I will carefully maneuver it into its position. In this play, in this maneuver, you have to be very careful that you don't again pull out the capsular tags. See how carefully I am managing it. No hasty movements at all, no forceful movements at all, and just rotated it to my desired position, which is perpendicular to the torn capsule. Again, the IA, we have to be very gentle here. Again, look at the pressure, it is just 50 centimeters, and I am trying to wash off all the viscoat or the hylucoat which I have placed. And it is important to wash out that, because it is a high molecular weight visco-dispersive agent, and it has to be aspirated out, otherwise it may cause raised IOP. So here I had wish to go behind the IOL and wash off some of the visco there, but because the capsule is already torn, I don't want to take that risk. So the rest of the little bit of visco which is in the bag will definitely come out and get absorbed, because the capsule is already torn and there are spaces around the IOL to come out. So in this particular patient, I would like to start the patient immediately on some anti-glaucoma medication and more frequent steroids to take care of the initial inflammation, but the post-operative visual outcome as well as the refractive outcome will be excellent. So the rest of the visco I am just trying to wash off a bit, not trying too hard, because you have to be very careful not to make too many AC fluctuations and cause extension of rexis here also. So thank you for watching. You can use the same principles in your Phaco in case, because occasionally there will be some CCC extension during routine surgery as well, and you may have to do Phaco in such cases. But this is very safe method to do it. Just be careful and use lot of good viscoelastic agent, not just methyl cellulose but high molecular weight dispersive agent. Thank you so much for watching.